much for having me here. It's a great honor. I have no disclosures. This is what we will talk about in the next minutes. I will talk about T-branch graft description, some planning and anatomical suitability, patient selection, IFUs, enduring deployment, some tips and tricks, and step by step, I will end with some take-home messages. As we all know, the T-branch is the graft platform for off-the-shelf treatment of thoracoabdominal aneurysm. It has suffered some changes in the years, but now, as we know it now, we have a B-modular device with two components, a main component, which is a tapered from 34 millimeters proximally to 18 distally, in a total length of 20 centimeters. We must be aware, very aware of the dimensions of the graft, the takeoff of the branches, the size of every branch, diameters. This is one of the most important messages that I have. Keep in mind that we must know very well the graft, all its features. And the distal component is like a regular EVAR to fit in the first component. This is an overview of the delivery system, very friendly. And the markers. Once in place, we must focus on the markers, the radiopaque markers of the device. We have 3 markers above and below the branches that allow us to orientate medially the graft. And then we have the tick marker below that must be orientated like a tick marker, in fact, to be anterior. And we have the branch markers, 5 dots for each marker, that allow us to position the good positioning of the graft and allow us to check the position even if it's anterior or posterior too. We will see afterwards. Once we are planning a case, we must focus on the anatomical suitability too. So we must know the device and we must know our patient and the features of the anatomy of the aneurysm we will treat. So we need 4 things: access, proximal landing zone, distal landing zone, and know very well the target vessels. In terms of accesses, we need 2 femoral accesses. Our preference is always to do a cut down. And we need a brachial access too. We must be aware that the device is a 22F device, so it needs at least 6.5 millimeters of iliac. We always, as I said, like to have a surgical exposure. It allows us a rapid declamping and the faster change of catheters. The purse strings allow us to not to perfuse the limbs as soon as possible and not to lose the access to the artery. In terms of the target vessels, this is a chart, a grid that we can use to help us to see if the graft is suitable or not for the anatomy of our patient. We mark with a red dot, we have the marker of the SMA and then the relative position of the other branches of our patient. If we are inside that area, we are okay to do the device. With some experience, we don't need the chart or the grid, but it's a very good tool when we are starting to do it. We must be aware that the target vessels must be somewhere in between 2 and 4 centimeters to the branch of the graft, so to avoid a big bridge. As I said, we need a good proximal implantation zone, ideally a healthy aorta with a length more than 25 millimeters, with a diameter somewhere in between 24 and 30 millimeters, measured outer. With not very big angulation, avoid the 90 degrees angulation. And many times we need to work a little bit on the proximal implantation area. We need a graft, a TVAR or 2 TVARs. We need sometimes a hybrid solution or a 2-in-1 Cook device, which is a good option to reduce the aorta diameter and then be comfortable to put and suitable to put a T-branch. Distal implantation is, like always, I talk about the unibody, one size fits all, and then we extend with regular extensions or IBD or whatever. If we can, we end at the aorta, but the solutions are not very, at our disposition. Patient selection. If we do some adjunctive measures, we can have, in all cases, features for 2/3 of the patients. So it's not really an issue. The 2/3 in the patient for an off-the-shelf device, it's very good. We must stay stricted, at least at the beginning, to the IFUs. In this slide resumes a little bit what are the IFUs for the patient. In terms of exclusion criteria, this is available in almost all papers. I just wanted to focus that in our eyes, not all the exclusion criteria have the same value. Some are relatively important and some are extremely important. I will focus the extremely important in our eyes. Of course, it's of extremely relevance to have area where the branches will fit bigger than 25, otherwise we will compromise the opening of the branches. Of course, that we need to focus on the renal arteries, not to push in renal arteries below the 4 millimeters. Of course, some polar may be sacrificed. In this device, there are no room for inventive solutions. And one of the biggest and most relevant aspects is the access, as we will see in the next talks. To avoid complications, we need to prepare sometimes a good access. And of course, extremely relevant too is do not push the envelope with the SMA. Okay, every exclusion criteria in the SMA are to be taken into account. So in terms of deployment and step-by-step tip and tricks, we will always, when possible, stage procedures. We have these conditions, operative conditions, at our OR. We do the cut downs, as I said, to femoral and the brachial. We need to in place a 22F in femoral, as I said, and a 12 in the brachial. And of paramount importance is to check the markers outside the patient, as in this video. This is outside the patient. We must be aware that the device may be twisted inside the delivery system. So we must check how it rotates, how it behaves when we rotate clockwise, anti-clockwise, see the markers, feel comfortable with the device, and just then, afterwards, in place the device. Okay. If necessary to have confidence in the deployment, we should do a full lateral view. We must avoid the 180 malrotation. That would be a catastrophe. In the right corner below, we have this, emphasize the tick marker that show us that this graft is faced posteriorly. The order of implantation of the devices in the aorta, we always go top to bottom, T-VAR, T-branch, E-VAR, iliacs, from top to bottom. We first cover all aortic wall and iliacs that we want, and just afterwards we will do the branches. In this case, for instance, we need to treat a little bit better the proximal area. We came from the subclavian almost. We tapered 38 to 28, then we put in place another T-VAR of 32 inside the 28. We placed 5 centimeters above the celiac trunk, which is a trick too, to fit and to open afterwards the T-branch, as I said, to avoid the malrotation, to check the target vessels. And sometimes we need to have some compromise, as Professor said before. Sometimes we need to readjust while we are opening. Sometimes we need to by knowing the target vessel that it comes at that clock position, we can, while deploying the device, rotate, anti-rotate, and try to fit better to the anatomy of the patient. If necessary, if more confidence, we can go a little bit proximal. The cannulation, we come always from top. Some people do it from below with special sheaths, but we come from above. And another thing that I wanted to mention is that we need to have plenty of solutions, a good armamentarium in terms of bridging stents. We need to play with lengths, with diameters, with radial forces. We need to have plenty of solutions available. And we, in our practice, almost always reline. There is always something to reline, some curve to adjust, some landing zone to optimize. And that's why we realign almost branches. This is some images that we did on these cases, similar to everybody. And we conclude the procedure always with a completion angiogram with 2 projections at least. Okay. In the first angiogram we have at left AP projection and then a 45-1. So in conclusion, and as a take-home message, I would like to focus that planning is crucial. If you don't plan, you are failing. Sometimes we have to have a good compromise between the ideal and the suboptimal, but do not push too much the envelope. Adapt the repair to the patient. Some modification of the graft, we can do it. We can play a little bit with it. When we do adjunctive techniques, we can achieve more patients to this technique. We almost always reline and play a little bit with the armamentarium of the bridging stents and be aware of twisting. That's what can be a mess in the procedure, the twisting. Thank you very much.